Hello, I am Francisco Ponce. I'm a neurosurgeon at the Barrow Neurological Institute. Welcome to DBS Education. As I pull up my slides, I'm going to be talking about deep brain stimulation for movement disorders. And I perform a lot of these operations. I do a lot of treatments for movement disorders as a neurosurgeon. And deep brain stimulation specifically is a procedure that I perform entailing implanting a medical device underneath the skin. And this medical device is used to help control motor symptoms of conditions such as Parkinson's disease, essential tremor, and dystonia. Those are the three I'll be discussing today. It's like a pacemaker for the brain, and it uses electrical stimulation to deliver stimulation to specific targets in the brain that can help smooth or alleviate these motor symptoms. The important thing, I think, in the scope of this education seminar is that this is nothing new. It's been around for decades, and it's become standard of care in many realms, particularly in Parkinson's disease and essential tremor. DBS should not be considered a treatment of last resort. There's a lot of evidence that supports the use of deep brain stimulation in defining the timing and the indications that many times people stand to benefit from this sooner than they think. However, it's not a cure. If you turn the device off, the symptoms come back. And it does not replace medications in most instances, so it works in combination with medicine. So why go through the next 30, 40 minutes of this education class? The purpose of this is to equip you with information you need to make an informed decision, to better understand when to consider deep brain stimulation as an option, why you might consider deep brain stimulation, and to help reduce the fear factor, the concerns you might have of the unknown of considering a permanent implant like this. Also, there's a lot of information on the internet, and the intention here is to help you sort through some of that information with kind of, an initial step toward considering meeting with a neurosurgeon such as myself. Also to help learn what questions you should be asking and to take ownership of the decision of whether to proceed with DBS. Just because you may know somebody who has DBS or your neurologist is recommending it, it's incumbent upon you to get the information so you can understand not only the benefits of this therapy, but also what the risks are and the alternatives. What I try to avoid when I consent a patient for surgery is a scenario where down the road, 3 months later, they say, well, looking back, if I'd known then what I know now, I would not have had this done. And regardless of what that intervention might be, this is how I approach informing patients of the information they need to be able to consent for an operation. Deep brain stimulation is nothing new. And I said that earlier, and the goal here is to kind of bring people up to speed because this has been around in some form for decades. Initially, it was an ablation that people used to treat the brain to alleviate movement disorders. So an ablation was made back in the 1950s, and it was in 1997 that the first deep brain stimulation procedure was performed in 1987 as an alternate therapy to an ablation, basically making a brain pacemaker. It was FDA approved for essential tremor in 1997 and FDA approved for Parkinson's disease in 2002, and then for dystonia in 2003. So these are some milestones in this therapy. So it's been a couple decades since FDA approval of this therapy. It's a surgical implant. So I implant the device. My goal is to do it accurately and safely, and it's actually the neurologist who turns the device on and programs and optimizes the parameters of stimulation. So there's three main components I'm going to discuss here. The first is the electrode, and the electrode is also known as a lead, is what goes through a hole about the size of a dime into the brain about 3 or 4 inches, and it's a thin set of wires that carry the electrical signal to the node within the brain that can help reset the abnormal circuits associated with these movement disorders. So the lead is what delivers the electricity to the brain. It consists of 8 small contacts that can be turned on or off depending upon the optimal location for stimulation. So there's the electrodes, there's the cervical extension. That's a wire that goes underneath the skin, and it connects the brain wires that are a bit more delicate to the internal pulse generator, the pacemaker in the chest. So this is connected to the brain leads through an incision that's a bit above and behind the ear, uh, and it connects to the brain leads and then passes underneath the skin across the collarbone, and then plugs into the neurostimulator or the internal pulse generator. So that's the second component, the cervical extension. And then the next component is called the internal pulse generator, or the IPG, which is what contains the battery. And some people think of it as the battery, but this is the pacemaker, and it's placed in a similar location as a cardiac pacemaker. And this contains the power source of the deep brain stimulation system, as well as the hardware that allows the neurologist to generate and control the therapy stimulation. It's placed underneath the skin in the chest, and there are options in terms of rechargeable devices that may last longer, that are smaller but require maintenance, or non-rechargeable devices that you set it and you can forget it. And decision based upon where to place it and what device to use can be informed by what your hobbies are, your lifestyle, your body habitus, how big you are, and additional factors to decide which is the appropriate device for you. Currently, there are three manufacturers making DBS systems in the United States: Boston Scientific, Abbott, and Medtronic. They all function in a very similar manner. Each has their unique features, and it's important that you discuss these devices with your healthcare provider, who will assist you in choosing what might be the right one for you. I won't get too much into these specific devices. These change year to year. There's been a lot of active advances in this technology just in the past couple of years. I'm going to talk about the three primary indications for deep brain stimulation: Parkinson's disease, essential tremor, and dystonia. Starting off with Parkinson's disease, let's turn up this volume. Parkinson's disease, when should you consider deep brain stimulation if you have Parkinson's? To be considered a candidate, you should have at least 4 years of confirmed idiopathic Parkinson's disease. This is often based upon symptoms such as slowness, stiffness, or tremor, and a good response to medication. So a history of responsiveness to levodopa medication, meaning that you have Parkinson's, but you take medication and you improve. So you want a robust history of that. And so patients who've been experiencing one or more of the following: fluctuations in their symptoms, so where their symptoms are not consistently controlled over the course of the day, prominent tremor that may not respond to medication, or dyskinesias. And this video I'm showing right here is of Parkinson's dyskinesia that are a side effect of medication that people start to develop or may develop over time. So what does deep brain stimulation help with Parkinson's? It helps with the cardinal features. The cardinal features of Parkinson's are not just tremor, which we often think about tremor as part of Parkinson's, but also the stiffness or rigidity and the slowness of movement, or bradykinesia. So the cardinal features of Parkinson's are tremor, rigidity, and bradykinesia. These tend to respond well to medications, and these respond also well to deep brain stimulation. Given that most patients do have a response to medication, why consider a surgical intervention? It's because of the side effects that occur over time, where people may develop motor fluctuations, where their symptoms are fluctuating between good and bad, or they get the dyskinesias like that video. And so deep brain stimulation can be used to help increase the on time without dyskinesias, so thus reducing dyskinesias and reducing the motor fluctuations. I think it's useful to consider a day in the life of Parkinson's. I'll be showing the next slide, but other benefits of deep brain stimulation would include diminishing dystonic features like painful toe curling, or some patients are taking a lot of medications or taking it 7 times a day, for example. So DBS can help reduce the amount or frequency of medications. This is a patient diary. So day in the life of Parkinson's, you can see 7 a.m., 8 a.m., 9 a.m., midnight at the top. Patients eating breakfast, lunch, and dinner at the bottom, and their medication regimen is shown where they're taking pills 4 times a day. And this illustrates the on time, which is how good they get with medication, and the off time, which is basically what their Parkinson's looks like without medication. And this is intended to illustrate the fluctuations a patient experiences between the on time and off state over the day, as well as dyskinesias they may develop in between dosing. And so what deep brain stimulation does, in essence, is capture that best response patients experience from medication and sustain that response. So you get more of this on time and then without the dyskinesias. So in combination, more on time, fewer dyskinesias is what we seek to accomplish with DBS. And we can measure this by seeing how patients look, say 6 months after surgery. If they come in off their medication, we can actually measure what that off medication state is, and that should have improved. We see a smaller gap between the on and off medication states with deep brain stimulation on board. Deep brain stimulation doesn't help with everything. Patients may develop problems with balance, difficulty walking, freezing of gait over time. They may have difficulty with speech or swallowing. They may develop cognitive problems, depression, anxiety. These are less likely to improve with DBS. Now, if somebody has gait problems that improve with medication, that's a good predictor that it'll actually respond to DBS. So if a motor symptom does not respond to medication, it's less likely to respond to DBS. The next condition we treat is essential tremor. And Parkinson's tremor tends to be a resting tremor, whereas essential tremor is an action tremor. Somebody trying to write, drink, this is when the tremor gets in the way. It is the most common movement disorder, and it's a chronic involuntary rhythmic action tremor. People typically don't notice it at night. It doesn't interfere with their sleep, but it affects their activities during the day. It's usually the hand, arm, sometimes can affect the head, voice, and tongue. Essential tremor can be familial in about half of patients. The lights just turned off in this room. That's why the lighting just changed. The most common medication for this is propranolol. It's the one on-label treatment for essential tremors. Propranolol. Primidone is another one, but other medications can be used, such as other anti-seizure medications. DBS can be considered when medications aren't working, and when the tremor is interfering with activities of daily living, such as eating, dressing, writing. When these are significantly impaired and medications aren't helping you accomplish your goals, it makes sense to consider more advanced therapies, and essential tremor is one of them. Deep brain stimulation is one of them. The third condition that we use deep brain stimulation for is dystonia. This can be a genetic condition. It's a medical condition that causes severe involuntary muscle contractions, and this can force the body to assume twisting, repetitive, or painful postures. Torticollis would be an example of this. Medical treatments for dystonia are pretty limited and are typically aimed at reducing the spasms, the pain associated with this, or disturbed postures. Botox is an example of a commonly used medication for dystonia. Candidates for DBS are those patients with chronic primary dystonia, including cervical dystonia or torticollis, who have not had success managing this with other modalities. So to consider deep brain stimulation, it's important that you're in a good state of health. You know, as we see the population getting older, people with comorbidities or multiple medical issues continue to seek elective treatments for their conditions, even though they may not be optimal candidates for surgical intervention. So it's important that you're in an overall general good state of health, that you get medical clearance if you're being treated by specialists, such as a cardiologist, a pulmonologist. It's important that you're willing and able to continue with the follow-up after deep brain stimulation with your neurologist, because the neurologist will be turning on the device, and it's an iterative steps of adjusting the device, adjusting medication. So you're going to need appointments to optimize the benefits of DBS. And to that end, having family or community support to ensure that you're able to attend these appointments and manage the device is important. It's also important that you have realistic expectations, right? This is not magic. You know, we know what this is going to help with. So it's important that we understand what your goals are and that you have realistic expectations. You know, especially depending upon age, that your family's on board and that they understand what this is going to help with and what this is not going to help with. And as well as discussing with your doctor what your goals are and your care with these conditions. The process we go through is initially with the neurologist, discussing this with your neurologist, with your physician, what this option is. Typically, if the neurologist does not offer to, you're unlikely to consider this. Once you do this, then we do this step, the DBS education, which is what we're doing right now. At some point, it's useful to have had an MRI of your brain to rule out other causes of your condition. And once you're looking at considering DBS, we do so-called on-off testing for Parkinson's patients. That's when you come in off medication and the neurologist assesses and quantifies your response to medication by testing you off medication and then a couple hours later testing you on medication. Standard of care, especially for Parkinson's, is to be evaluated by a neuropsychologist to understand your cognitive function, and then evaluation by a neurosurgeon such as myself. Many centers have a consensus committee. So every month or every couple of weeks or every 6 weeks, I will meet with neurologists and psychologists and physical therapists to review and discuss every patient who's considering surgery. This team is made up of multi-specialties to evaluate all the various angles of one's disability as well as their goals. And we come up with a consensus based upon appropriate patient selection. We discuss which targets are appropriate. We decide whether to treat one or two sides, and we discuss the device, which type of internal pulse, which type of battery would be most appropriate. In terms of locations, there's multiple locations in the brain that we know if we place an electrode there, we can modulate movement and improve motor movement disorders. So these are the three most common targets I use for essential tremor, Parkinson's, and dystonias, the subthalamic nucleus, globus pallidus interna, and ventral intermediate nucleus. So we use the STN for Parkinson's disease. This helps control the cardinal features like stiffness, slowness, and tremor. It also helps reduce the medication requirements. So we often use this when a goal of surgery is to reduce the medication requirements. It has a very dramatic effect on tremor reduction. Sometimes it can affect speech in a negative way. It can be a side effect. The globus pallidus interna is another FDA-approved target for tremor for Parkinson's. For Parkinson's disease, this helps to reduce the same symptoms, slowness, stiffness, and tremor. It also has a very impressive reduction effect on dyskinesias. We may see some medication reduction. And sometimes it seems that with GPI, programming may take a little bit longer than with STN. The VIM, ventral intermediate nucleus, is the target for essential tremor. And this helps reduce tremor, but we can use this also in Parkinson's, but in the setting of Parkinson's disease, it only helps the tremor. It does not help with the stiffness or the slowness. And similar to STN, we may see side effects involving speech. So speech may be affected, also balance. And we know that to be the case, especially if we treat both sides of the brain. Typically, if you turn the device off, those side effects go away. And then with dystonia, for dystonia, we typically use globus pallidus interna. And for dystonia, we usually do bilateral treatment, meaning we're treating both sides of the brain. So some familiarity with these targets, especially one of them is going to be used for you. I prefer that patients know these words or at least can recognize them in a consent sheet. Deciding whether to do one or both sides, probably well over 90%, probably over 95% of my patients get both sides treated at once. But if there's cognitive issues that are of concern, or if somebody doesn't have any symptoms on one side, we may consider unilateral treatment. Now, keep in mind, the left side of the brain controls the right side of the body, vice versa. So the brain signals cross. So talking about deep brain stimulation, in the United States, we do this operation in separate stages. We do a first stage, which is where we put the leads in the brain. In the second stage, we pass that cervical extension down and plant the generator in the chest. The lead placement is done as an inpatient, meaning that you spend the night. So it's typically 1 or 2 nights in the hospital. It can be longer. Sometimes people have to go to acute rehab after surgery. They don't go home. In patients over 75 with Parkinson's, I'm usually assuming we're going to spend 2 nights in the hospital. The surgery itself takes about 1.5 hours for the surgery, but there's a lot of preparation time. So operative time, the time in the operating room can be about 2 to 3 hours. And again, this is when the leads are placed in the brain. About 10 to 14 days later, the patients come back for the second operation, and that's when an incision is made above and behind the ear, and the cervical extension is connected to the brain leads and passed underneath the skin, and the internal pulse generator is implanted and connected to the cervical extension. And this procedure takes about half an hour. It's an outpatient surgery. You go home same day, and typically during this operation, I remove the staples I placed during the first stage because 10 to 14 days have elapsed. So instead of taking those out in the clinic, I'm taking those out after I place the battery. And then you have new staples that need to be taken out in your follow-up appointment in my clinic. I performed this operation at 2 sites, both at the Barrow Neurological Institute at St. Joseph's Hospital Medical Center, as well as at Honor Health. You'll get information about this when you see me in clinic. We'll send this to you in the mail. It's slightly different experiences at the 2 hospitals. At St. Joe's, you come in the day 1 or 2 days before surgery. You get an MRI, you get a CT scan, you see an intensive care doctor, an intensivist, or a hospitalist, and internal medicine doctor. They may order an EKG, chest X-ray, order some labs, and this is how we get our medical clearances. If you see a specialist, we usually need you to come in with the clearances from your specialist, and internal medicine will review all those records. They give you bathing and showering instructions for before surgery at that time, as well as the instructions about stopping medications. Of course, if you take blood thinners, those should have been stopped earlier than this appointment. At Honor Health, it's slightly different. You get your pre-op clearances from your primary care doctor and your specialists before you show up, and you come to the hospital. And then the day of surgery, you show up a little bit earlier because you actually get your MRI and your CT scans on the same day. And we don't use sedation for these. So if you're claustrophobic, it's very important you tell us so we can factor that into surgical planning. Preparing for surgery, you'll receive detailed preoperative instructions with date and times and maps that will be mailed to you from my office. Before both operations, it's important you don't eat or drink anything after midnight. So you have to fast for both of these operations. So don't go and eat a breakfast burrito before you get your battery placed. Parkinson's patients, it's important you bring your own medications. This will help with your experience in the hospital. It's better if you're able to take your own medications versus waiting for the hospital to provide you with those. And it's important that you're attentive to where you're supposed to be and when for both operations. And these times can change. So we'll be trying to reach out to you a day or two or a week before surgery, because sometimes we do change the times of your operation. A little bit more detail about the first operation. This is the one where we place the electrodes. I have you under anesthesia for this operation. You're asleep. That's how I do it. I do not perform the operation with the patients awake. If you look this up online, there's a lot of videos of people awake for this operation. That's not how I perform the operation. You'll be under anesthesia. And once you're asleep, I place a stereotactic frame. A CT is obtained using this device shown here. The hair is clipped. You're prepped and draped. I make semicircular incisions to make the burr hole. The burr hole is the hole in the skull that's about the size of a dime. That's right behind your forehead. I place the leads. I verify with the CT that the leads are placed in the appropriate location. Then I secure the leads, and I tuck the redundant wire behind underneath the skin over toward your ear, and then I close the staples. So that's a very brief summary, and I'll show some more slides kind of highlighting those steps. This is what an MRI looks like. I use this to plan where I want to go. And actually, both these MRIs show these little white circles are the actual electrodes. So these are MRIs done after the leads are placed. But I pick where I want to go based upon your MRI. The incisions are half circles, and they're done around the hardware that's going to be implanted. And this is the small burr hole about the size of a dime that's used to place the electrodes. The surgery, I typically use a surgical robot. This is by Globus. I helped develop this robot. And this is a picture with the CT scan in place, the patient's draped with the robot in position. The alternative is stereotactic frame that I also use, where we manually set the coordinates for lead placement. Sometimes patients will experience a honeymoon after the operation. That means that even without the battery placed, they're not shaking, they're walking better, they don't feel like they need as much medications. So it's a honeymoon. They like the feeling. They may have headaches. That's variable between patients. There may be some confusion, cognitive changes, attention problems. There may be some brief word finding difficulty or slurred speech. There may be short-term memory difficulties. This can be from the surgery or from anesthesia. There may be balance issues walking. It's not uncommon to see swelling or bruising around the eyes. This is all things that people may experience after surgery that just will take some time to resolve. You will feel bumps, behind the forehead. There's the bump. This is actually the device that covers the hole that it makes. So it's not a hole. It actually ends up being a bump that you can feel underneath your skin. And that's what secures the electrode without crimping it, without shorting it. There's another bump that's up above and behind the ear, and that's circled right here. And that bump up here is the connection between the extension that goes down the neck and the device goes in the brain. And between the first and second operation, I actually cap the lead so that there's a similar bump to what you're going to feel long term present after the first operation. The second operation, 10 to 14 days later, is outpatient surgery. I make an incision above and behind the ear. I pass underneath your skin the cervical extensions, and I connect them to the battery that I place, usually just over or within the muscle. Sometimes people find that this second operation hurts a little bit more than the first operation because of soreness to the chest. After you complete the battery replacement, you may notice some neck stiffness. It's important to do some neck stretches because sometimes the scar tissue that forms around the hardware may create the sensation of tightness down the neck. There may be tenderness at the site of the connector incision that's up by the ear. Some patients find it useful to use a travel pillow to sleep so that the pressure is not going on that area. There can also be bruising in the chest. That's not uncommon, and women may consider using a sports bra to provide some extra support after the placement of the battery. Once you go home, I usually say 3 nights don't wet the wounds for 3 nights. That's after the first and the second operation. So you can apply the ointment. Aquaphor is great. Bazotracin is also an option. Apply it twice a day. Don't get your wounds otherwise wet for 3 nights. You'll have a dressing on your chest. After 3 nights, you can take that dressing off. You can start to shower. Use some common sense to avoid falls. Don't drive for the first several weeks. Don't apply hair dye for about 6 weeks after the second operation. Don't submerge yourself in hot tubs or pools for about 6 weeks after the second operation. Don't push, lift, or pull anything over 10 pounds, again, for about 6 weeks after the second operation. And again, you can stretch through your neck because you don't want things to get too tight in your neck. So neck stretching is advisable. Up to the upper left, those are the staples on the semicircular incision. Upper right, that's the incision where the battery is. And then you can see in the middle, if you look closely, you can see the semicircular incisions on this gentleman who's bald. And so the scalp actually heals very well following this operation. There's always risks of an operation. We always include death, coma, stroke, bleeding, paralysis. But the things I'm really focused on would be infection, circuit problems with the hardware where the hardware gets shorted, or have an open circuit where we can't deliver therapy. Seizures can occur, stroke-like symptoms, even just from temporary swelling. You can get a bleed. That's why it's important to really be on top of your anticoagulation management. If you take anticoagulation medications, that you stop them on time before surgery. Ischemic stroke is rare. If you have a lack of benefit from therapy, it may be needed to reposition the electrodes within the brain or replace the leads due to faulty circuits. About a quarter to a half of patients with Parkinson's may develop some decline in their verbal fluency within 6 months of undergoing surgery, but less than 5% of those patients find it bothersome. 5 to 10% of patients are at risk for depression in the first 6 to 12 months, so be aware of that. And typically, we recommend that you get follow-up neuropsychological testing 6 months to 1 year after surgery. After the operation, you'll have an appointment with your neurologist. The neurologist will be the one turning the device on, and we try to have these scheduled before surgery so you know what comes next. During the first programming, they survey the entire system, looking at each contact, look for side effects and benefit to get a lay of the land. And the objective is to find settings that will help maximize your symptom while minimizing the benefit. And especially with Parkinson's, once you get started, you'll slowly decrease your medications depending upon the goals of treatment or your neurologist's style. But it's iterations of, kind of 2 steps forward with the device, 1 step back with the reduction of medications until you optimize medication reduction and therapeutic stimulation. And it's good to think about this as taking between 3 months to 6 months total. After the operation, you cannot undergo diathermy, you cannot undergo transcranial magnetic stimulation. When you go for elective other surgeries, there are safeguards needed when surgeon might use electrocautery, lithotripsy, therapeutic ultrasound, or MRI. So anytime you undergo these interventions, we'll get you in touch with the DBS representative or somebody to make sure that those safeguards have been taken. It's okay to undergo CT scans, X-rays, PET scans, fluoroscopy, or mammography. These are things that you can still undergo after undergoing deep brain stimulation. Dental work, I don't usually have any recommendations for antibiotics prophylactically, but it's good to wait about at least 3 months after surgery before undergoing any elective dental work. You don't want the drills or the cleaning tools to be placed directly on the neurostimulator or the areas where the electrodes are underneath the skin. If you undergo a sleep study or an EKG, you may want to turn off the neurostimulator to get better responses. And for surgical procedures, sometimes you'll want to turn the device off if you're going to be undergoing an elective surgical procedure due to the electrocautery use that many surgeons take advantage of. There's always you eventually get an ID card, and there's 1-800 number that you can call if you have any questions. Airport security, I usually tell patients to tell me you have a pacemaker. You don't have to get into specifics. That usually does it. You don't need to have your ID with you, but it can help. Do not go through the metal detector, but you may go through the body scanner because it's based upon X-rays, and X-rays are okay. Avoid being wanded. This also pertains to if you go through to a courthouse, a sporting event, anything where they're looking, at your body to look to see what you have underneath. In my practice, I accept all insurances, but that means that if you may be out of network with me. So I would require a prior authorization by your insurance to see me if I'm out of network. DBS is covered by pretty much all insurances. I don't have issues with insurances not believing in this therapy. It's standard of care. It's been around for a long time, and insurance covers it. So as you kind of look forward to the future, it's important to think, is DBS right for you? That's a discussion to have with your neurologist. You want to weigh the potential risks versus the potential benefits. It's important you have realistic expectations and have an open discussion with your doctor, but also your family, because your family may have not have heard this, and they may think this is some kind of newfangled futuristic therapy you're signing up for. But again, it's been around for decades. It's important that you have your questions answered. If you come up with a question, write it down so you don't forget it. We have a lot of resources available. We have a patient ambassador program, patients who have undergone this and say, look, I want to talk to other patients who are considering this. We have research studies that are ongoing. Our website has a lot of information about deep brain stimulation. You can watch how this surgery is done. This website right here is live surgery that I've recorded going through this with a stereotypic frame. I use the robot now. If you go to YouTube and you do a search for Ponce DBS, you'll find a lot of resources that I've posted or been posted with me. Some acknowledgements. A lot of this material has been largely developed by Meg Lambert, who was my nurse for years at the Barrow, and she now works with Medtronic, as well as Cindy Meckelfresh, who's our program manager for both deep brain stimulation as well as focused ultrasound. Focused ultrasound is an ablative treatment for tremor, also for Parkinson's tremor that is an alternative to DBS. I have a number of conflict of interests. I work with Globus, Boston Scientific, Medtronic, as well as Insightec, and I have financial relationships with them. And it's important that you're aware of that. And when you see me in clinic, we actually send you a video with all of my conflicts so you're aware of these. So thank you very much, and good luck in your decision-making process.